As all of you are kind of making your decisions between the breakout sessions to kind of catch us back up, I'll go ahead and introduce myself. My name is Gabe Hinojosa. I'm going to be kind of our moderator for this breakout session. It's going to be a little bit different in format than what we've been sitting through so far this morning. That's been primarily lecture based with slides and a lot of information. While that's incredible, this is going to be a lot more relaxed and informal. I don't have slides to review with you. I'm just going to spend a little bit of time talking about some supportive care measures that I find incredibly important, and then give plenty of time for you all to ask questions and hopefully address some questions that you have. Before we dive in, I will clarify in my introduction, I am not a physician, despite the upgrade in the title that they gave me on the slides there. So I'm a pharmacist actually here at UT Southwestern in Dallas. And so many of you, I'm sure, have interacted closely, I hope, with pharmacists along your care journey, and I hope that they've made a good impact and impression in your care. But a lot of what the pharmacist does in your role, in addition to kind of helping the physicians through the chemotherapy and the dosing and those types of things, one of the primary things the pharmacists are doing behind the scenes is helping to ensure that we have appropriate supportive care for you and that we're keeping you safe. So we look at what are the treatment that you are receiving? What other side effects or toxicities maybe have you already experienced? What side effects might we anticipate with this? And then we kind of help have those conversations with your physician and with you to make sure that we're protecting you and minimizing those side effects as much as we can, and then addressing anything that does pop up. So there's just a few areas that I want to highlight quickly before I open the floor to questions and kind of address what supportive care measures may be on your mind. So the first that I'm going to dive into is more disease specific. And so all patients with myeloma, and particularly newly diagnosed myeloma, those myeloma cells are contributing to bone destruction. And most of you, I'm sure, have received and are familiar with some of our bone strengthening agents like zoledronic acid or Zometa. Maybe you've had a drug like denosumab or Xgeva, but maybe you didn't quite understand why you were receiving that drug. And so the myeloma cell itself is releasing kind of chemicals that are causing the breakdown and destruction of that bone, because the bone in that process, when it's being broken down, is actually then releasing some chemicals that feed those myeloma cells and help them grow. So it turns into this kind of never-ending feedback loop of breakdown of your bone that can increase risk for fractures and what we call skeletal-related events, but that is also feeding the myeloma. So it's very important that we put a block to that very quickly. Some studies have found that as many as 80% of patients, when they're newly diagnosed, already have some lytic bone disease or bone lesions. And so it's very important that we intervene and kind of give some of these drug modifying agents. So that's kind of the number one thing that we'll talk about today. Starting on a bone modifying agent like zoledronic acid is very important. Guidelines recommend that patients should be started up front. There's some different dosing strategies, and there's 3 different agents that we can use primarily. So patients may receive different drugs and different doses, but we should all be started on something up front for at least 2 years. Continuing beyond 2 years is kind of a discussion up with the patient and the provider based on kind of what's going on with you at that time. But incredibly important, something that we should all be aware of and know why we're taking that agent. The next big area that we'll dive into and can answer more questions on as well as we go throughout the session is infection risk. So, infection is top of our mind at all times. Infections, in fact, is one of the primary causes for non-relapse mortality in patients with myeloma. So we can do everything we can to keep the myeloma under control and keep you happy and healthy and living, but we don't want you to die from an infection. And so we take a lot of precautions because we know that everything that we're giving can, to some degree, decrease your immune system, but also the myeloma itself is decreasing your immune system. Depending on what clonal component we're making a ton of, that means we are not focusing any energy on making some of these other antibodies that your body needs to fight infections. So One of the key areas that we'll think of first is HSV or VZV. This is the virus that is living in all of us that can flare up and cause shingles. So patients on most therapies should be on some sort of prophylaxis, either with acyclovir or valacyclovir. Guidelines recommend any patient on a proteasome inhibitor or our monoclonal antibodies like daratumumab should be on some prophylaxis for that virus and could continue throughout treatment, and then at least 3 months. Patients getting a transplant are going to be on it for at least a year, and then we'll decide if we can stop after that based on some of your cell markers. And then actually with our bispecifics and CAR T, some guidelines recommend we continue that for life. So that prophylaxis could be indefinite. And while HSV and VZV reactivation are not likely going to cause mortality, they can cause a lot of morbidity and make you uncomfortable. So we can have very painful kind of rashes. And even once the rash physically disappears, it can be very common to have some of that nerve pain and burning sensation for months after. So it's something we take seriously. So always make sure that's a discussion you're having with your provider. You know, the medications I'm on right now, do they require that I'm on this acyclovir prophylaxis? And if so, take it seriously and try to stay on top of that medication. One of the other primary causes of infection potentially is a decrease in our IgG, a component, an antibody that helps your body fight infections. And some of that can be from the treatment we're giving you, particularly our bispecifics and CAR T. Some of that is just from the disease itself. So we monitor IgG levels very closely, and we can replete it with an IVIG. So just we're giving you back the IV formulation of that drug. We can do that up to every 4 weeks. Again, keeping that IgG serum level within a normal range is going to go a long way at protecting you from viral infections, but also bacterial infections and fungal infections that could lead to some of that non-relapse mortality. We don't often see it with some of our upfront treatments, but especially in the relapse refractory setting, antibacterial prophylaxis with drugs like levofloxacin or suitable alternatives can be very common, especially after CAR T therapy, after transplant, or any very cytotoxic drugs that we get where that neutrophil count for your ANC is less than 500. Anytime the ANC is low, we can be at pretty big risk. So protecting you from those sorts of infections are incredibly important. I'm going to flip through real quick to find one or two more points before I take your questions. So another really important area of supportive care that we think of in myeloma is reducing risk for thrombotic events. So both the malignancy itself as well as some of the treatments that we can give you can really increase risk for blood clots. And some of those frontline treatments that we've heard discussed today, as many as 1/3 of patients could have a blood clot on drugs like RVD and those sorts of regimens. Some of that risk, as you know, is associated with the lenalidomide and that family of drugs. As many of you have had those, I'm sure you've done the extensive REMS programs and talked with someone about the risk for clots. But also the malignancy itself is kind of activating this inflammatory and coagulopathy state in your body that can tell your body that it needs to make clots to help protect itself. But we don't always need to do that. So aspirin is one of the primary agents that we use, but depending on other risk factors, and there are scoring tables that are available to you and to your physicians to help facilitate that discussion. Some patients may even need more aggressive therapy than just an aspirin. We might need kind of a more serious blood thinning agent. And then we often think that only patients on lenalidomide or pomalidomide need some sort of VTE prophylaxis like aspirin, and that is not the case. We'll have a lot of patients with multiple myeloma that still need that kind of antithrombotic protection, even if you're not on that specific drug class. So something to keep in mind and to have that discussion with your provider. We got to see a little bit of a highlight maybe during our cure hub of a patient that had been struggling with neuropathy. Neuropathy is a very common side effect of some of our medications. And oftentimes we do jump to treat, but as you saw, real world data from some of our patients, only about half of those patients that we saw in Cure Hub today said that gabapentin was helpful for them. Gabapentin is helpful for nerve pain in general, but is not always super helpful with chemo-induced nerve pain. Actually, some drugs like duloxetine have been shown to be more beneficial. But unfortunately, in the case of some of our myeloma drugs, some of the best supportive care measures we can do to minimize your neuropathy is just to change the way we're giving your treatment. So particularly drugs like bortezomib that we think of, they can be given as IV or as a subcutaneous shot, so just a quick injection. We see that patients have a lot more of that neuropathy getting it as an IV versus the sub-Q shot. There are also different dosing strategies published, either giving it twice weekly or once a week, and no surprise, giving it twice per week does increase the risk for that nerve pain. So we can find oftentimes that just decreasing it to once a week and giving it as the shot versus the infusion is all the supportive care need that we need to minimize some of that neuropathy. But before I eat up too much of our time, I do want to leave plenty of time for questions that all of you may have. So I'm not going to dive into too much on supportive care, but I'm happy to answer any questions related to some of the topics that I very briefly discussed, or any other supportive care questions that you may have, treatment of side effects or other things that you've read or experienced.
On the aspirin 3 times a week, but it is causing some skin problems that I'm having to deal with, and I would love to stop it. I'm only taking Dara once a month, Kyprolis 3 times a month, and Dex 3 times a month. Do you have any indication on whether the aspirin is needed?
That's a wonderful question. So just like with our mainstays of treatment, even the supportive care drugs that we're giving you can have side effects. And so with any blood thinning agent like aspirin, some increased bruising and things like that may be noted. So these are not benign, and while we do want to use them effectively, we want to make sure that if we're able to stop them or they're causing us issues, that we can. So as I mentioned, there are a few different scoring systems. One of the kind of more in-depth one is called the IMPEDE VTE score, and these look at the treatments that we're on, as well as if we've had if we have central lines, if we've had procedures, if we've had history of clots before, if we've had any clots in the past, or if we have any coronary artery disease, history of stroke, other risk factors that might predict the risk for clots. So I would encourage you to have a good in-depth discussion with your physician using one of those risk scores like IMPEDE VTE. It's IMPEDE, the IMPEDE VTE score, and they'll be able to do a more thorough review of your medical chart with you. I don't want to put words in their mouth and say that it's okay to stop without reviewing every kind of risk in that chart with you, but just off of the medications alone that you're on, I would say that we may not need it. But the dexamethasone, for instance, steroids can also increase risk for blood clots. And so depending on some other risk factors that you may have in that scoring table, along with the dexamethasone in your regimen, might still be enough to push you over to where we need that. But wonderful question.
Right.
I just have a question to what you were saying. Just for clarification, you said even if you're not on Revlimid, you still need to take the aspirin because of multiple myeloma?
So not necessarily. So again, it's going to be driven by these risk stratification scoring tables that I'm referring to. So being on an IMID is going to require that we're on the some sort of VTE prophylaxis, whether it be aspirin, one of our direct oral agents like apixaban or Eliquis, or whether we're doing injections with Lovenox. So across the board, we automatically say everyone on lenalidomide or pomalidomide is going to require one of these drugs. The statement that I was making is that we may often miss that some other patients still need to be on it. Having myeloma alone is not an indication to need VTE prophylaxis. So everyone does not need it. And so I'm glad you clarified that. If it sounded that way, that was not my intention. Everyone certainly does not need it, but we often fall into the trap of thinking we are on lenalidomide or pomalidomide, so we need VTE prophylaxis, and then once those drugs are stopped, we no longer need it. And that may not be the case, as our first patient has questioned this morning, still being on aspirin, and that very well may be needed based on one of those risk scores, even though she's not on lenalidomide or pomalidomide. Good question. The question up front.
Yes. Besides medications and infusion with Zometa, etc., could you recommend some kind of food or special diet for bone strengthening?
Wonderful question. So, a lot of this bone kind of breakdown and bone destruction we often think of, can lead to changes in our calcium. And so making sure that we're having calcium-rich diets is important. And of course, adequate vitamin D levels as well will help your body maintain and utilize the calcium appropriately. So those are all going to be good things. And generally, when we're starting a bone modifying agent, they will closely monitor calcium levels and make sure that we're at an okay level at baseline. Oftentimes, as your body is going through that bone destruction process, the calcium levels in your blood can actually be very, very high because part of that bone material that's being broken down and released into the bloodstream is calcium. While calcium is important for our bones, it does get used a lot of other places. And so calcium, if the level is too high, can lead to heart arrhythmias and different things. And so we want to make sure that we're keeping it at a balance. So I'm not going to say go out there and have tons and tons of calcium. But we do know that as we give these bone modifying agents, we can typically see a decrease in your calcium. So generally for patients who are not high at baseline, their calcium level was not high before starting a bone modifying agent, we will generally prescribe or recommend that they take some calcium supplementation as well for the time that they're on that bone modifying agent, because we know that those agents can decrease your calcium. One more, and then we'll come to you over here.
Hi. So I had a question regarding the vitamin D. So my chiropractor had mentioned a thing called micellized vitamin D, which is a tiny liquid bottle, and a tiny drop is 1,000 IUs of vitamin D, a liquid form. Are you aware of that, and the impact versus the traditional pharmaceutical grade vitamin D tablets?
That is not something I'm particularly familiar with, to be honest with you. So I'm not sure that there's a benefit to the liquid vitamin D versus using, oral vitamin D. There are different dosing units with all of these agents, so be very careful when you're dosing yourself or reading things online, looking at IUs versus milligrams, and there are some conversions based on molecular weight of the agents and stuff that, again, will be over my head to get into today without looking at a reference. But be careful with that, I will say. As far as solid versus liquid formulation, I'm not aware of any big difference, but I could be wrong. And then a question over here, sir.
Yes. Excuse me. I wanted to ask a question about fatigue. Of all the drugs that we take, Revlimid, Enlaro, Dex, are some of them have higher fatigue levels, or is that all individual? And I'd just like to know if there's any ranking out there for you as a pharmacist to say that this drug, Revlimid, will create more fatigue than Enlaro.
Sure. So there's going to be a lot of factors that play into that, but I'm going to try to break it down for you as best as I can. So it's really going to depend on what then is the cause of that fatigue. So oftentimes with myeloma or with any type of blood cancer, one of the primary causes of fatigue is a decrease in your hemoglobin levels. So the numbers that we're looking at to measure your red blood cells. Kind of the oversimplified explanation is that those red blood cells are carrying oxygen and energy all over your body all the time to give you the energy that you need, and it's providing that oxygen and energy to all of those cells. So if you have fewer red blood cells to do that, you can feel that. And so that can often present as fatigue is kind of the main way we think about it. In very severe cases, you could even feel short of breath because your body is recognizing it's not getting enough oxygen. So one of the primary causes that we think of with fatigue then is going to be decreases in hemoglobin, which is going to then lead us to kind of rank therapies to what you're getting at in drugs that can be more likely to drop our blood counts. And so in general, we will have more intensive treatments. And so we think about treatments that we would receive, prior to an auto transplant or something like that, that are very high doses that we know are going to totally wipe out our blood counts. That's going to be kind of at the top of the list. And then as we progress through, our agents like lenalidomide and pomalidomide can certainly cause decreases in blood counts. That's one of the main reasons that, we often see them being dosed for, a certain number of weeks and then 1 or 2 weeks off. That kind of off block is to allow, if we have had a gradual dip in blood counts while we're on therapy, then to allow for those blood counts to kind of return to normal before starting. So a lot of the cycles that we think of with treatment are built in a way to help allow time for the body to recover appropriately from some of these side effects, particularly like low red blood cells that would be causing fatigue. But that's not the only thing that can cause fatigue. So particularly agents that might put you at risk for infusion reactions, where you're going to be getting pre-medications. We often don't think about, all the pre-medications that we're getting in supportive care. Just like our first patient this morning pointed out some side effects from the aspirin. We very commonly use drugs like Benadryl before we give, a daratumumab injection or infusion or many other of our treatments. Like our bispecific agents, we're going to be using diphenhydramine or Benadryl before. So a lot of times what we think of as fatigue from the treatment is actually fatigue from the really high doses of Benadryl that we gave you on your day of treatment, and it takes a few days for you to maybe come out of that fog. So even with some of our weekly bispecific agents, if you're in a period where you're still getting some of that diphenhydramine or other agents like that, it can take you a few days to come out of that fog. Now, generally with all of these agents, we can get to a point where we're not having infusion reactions and things are going well, and the provider can be comfortable pulling off some of those pre-medications. And so in those cases, the fatigue can improve pretty significantly. And then kind of the other agent or both treatment option and supportive care that we're using is with our steroids. High dose steroids, they can certainly give you a boost the day that you're getting it, but a crash after those high doses of steroids are very common and very real. And so while you may not be tired the day you get your steroids, you can certainly have that kind of low after. So I would say the Benadryl and steroids are things to keep in mind. And then with regard to ranking other things, it's really just going to rely on kind of the intensity of the treatment and how likely it is to decrease your blood cells.
I've been taking Xgeva every 3 months for about 4 years, and there's always the discussion about your jaw. And every time I go to get my teeth cleaned, I'm a little bit leery of what they're going to find. So what happens if they do find something that needs to be invasive to your jaw? Is there any prevention for that, or what are we talking about?
So these agents like Xgeva can cause osteonecrosis of the jaw. So they can cause, basically, while we're helping to prevent bone destruction elsewhere, it can cause maybe some demineralization and some minor bone destruction, particularly there in the jaw and where the teeth are setting into the jaw. So that's something that we're monitoring closely. There's really no way to prevent it other than routine screening and monitoring, early detection, and then stopping the offending agent. So there's not anything I'd recommend to avoid it or prevent it. But, it's certainly something to keep in mind, and then continue with those routine exams so that if there's any issue, it would be detected very early, and then we could intervene and stop the offending drug. Ma'am, over. Yep. Yep.
Okay, in a perfect world, and your doctor's not in the room, and you're going on vacation, what antibiotic would you say you want to have on hand, could not get to the doctor a week?
So that is going to depend on a lot, and it's kind of an impossible question to answer. I will say that, the main risk factor for your bacterial infections, which is what your antibiotic would protect you from, your main risk factors for bacterial infections are going to be what is your neutrophil count, or ANC. So it's going to depend on what myeloma treatment you're on and if it's causing your neutrophil count to be low. If your neutrophil count is normal, then we're probably not going to be too concerned about bacterial infections. The other thing that can contribute to that pretty significantly, like we talked about before, was a low IgG level. That antibody in your body helps protect from a lot of different infections, including bacterial infections. So maintaining a normal ANC level and a normal IVIG level beforehand would help, probably more than taking something with you just in case. In general, if we're going to start like a preventative antibiotic, our go-to that is used most commonly across all blood cancers is levofloxacin. It gives good broad coverage for some gram-positive and some of the scary gram-negative bacteria that we think about, as well as kind of some of the things that could cause GI upset. Yeah.
I'm a newly transplanter from March. I did stem cell. And I just wondered if exercise can minimize bone destruction. I don't have fatigue, and I'm just on Revlimid and not on any other drug. Can exercise minimize fatigue or bone destruction?
Exercise is your best friend. Other than the wonderful doctors Anderson and Kahn sitting in front of you, your other best friends in this room will be exercise. Exercise is going to be the best medicine. Okay, so there may be some brief periods of time right after transplant where platelets are low and we don't want to increase any activity that could cause bleeding. So there might have been a time frame where they told you to minimize some strenuous activity, or maybe we just had a new central line placed and they're telling you not to do certain curls and exercises that could interfere with that line. But outside of that, exercise is wonderful. So it is certainly going to help keep your strength up. While some of our agents, as I'm sure we discussed this morning, can cause a lot of weight loss, none of what we do are a weight loss program. We want you to keep your strength up and keep that weight on, and so exercise is going to be a good way to do that. Conversely, the way we talked about with our gentleman over here, that one of the primary causes of fatigue is that decrease in your red blood cells. If we're exercising a lot and we're moving and we're telling our body that we need more oxygen, it's smart enough to realize that it doesn't have enough blood cells to give you the amount of oxygen that you need. And it'll trigger a pathway in your body to start making more blood cells to be able to deliver more oxygen to those muscles, and overall will give you more strength and decrease your fatigue. Where we can get in trouble is when we say, oh, I'm feeling pretty tired and fatigued, I'm going to lay around and rest for a few days. You lay in bed for a day, that turns into a week, into 2 weeks, into a month. You're still feeling fatigued, you're probably feeling more fatigued, and you're just getting weaker and weaker because your body doesn't realize that it needs more oxygen. So yeah, staying as active as you can. It's not necessarily going to do anything to strengthen the bone, but it's going to strengthen all the muscles and ligaments that are the support around your bone, and can definitely decrease risk for some of those skeletal related events because you're supporting the bones. But overall, it's just going to make you feel better. It's going to give you more energy. But no heavy lifting, yes. Because again, it's not doing anything to strengthen your bone. So, that muscle is constricting, around the bone. So if the bone is weak, we could injure ourselves. So, be active, go on walks, do those types of things, just no bodybuilding.
Good morning, doctor. It's taking any of the herbal supplement is part of a maintenance for multiple myeloma. I'm talking about like all these magic mushrooms like turkey tail or whatever. Are there any actual clinical studies on using any of this supplement? Thank you.
That's a wonderful question, and there are a lot of products out there that might help, but none that really have good clinical evidence to suggest that they for sure do. And then the big pitfall there with any of these herbal supplements or food products and dietary supplements is that even if we had a clinical trial that said this particular product is going to help, well, then you're going to have 20 different companies making that product. And the way that your over-the-counter products are manufactured and distributed, they do not have any type of regulatory oversight to guarantee that for sure this capsule that says it has 100 milligrams of product X actually has 100 milligrams in it. You can have an over-the-counter product that one capsule has 100 milligrams, one has 5 milligrams, one has 500 milligrams. And so I generally, as the pharmacist on the team, recommend against all herbal or dietary supplements. I think that alphabet vitamins, vitamin A, B, C, D, E, etc., are all fine. Anything else, it gets tricky because we can have some side effects from these as well, particularly with mushrooms and herbal and root products. There are a lot of very well-known drug interactions, and so these over-the-counter supplements can interfere with your primary myeloma treatment, oftentimes making you more likely to have side effects. And so because of kind of some of those drug interactions and the uncertainty of how it's manufactured and exactly what is in it, my answer when those questions come across my desk is always no.
I would like to know if there's an advantage to taking lenalidomide for 28 days instead of the 21 days and 1 week off.
That is a wonderful question that I will defer to the roundtable discussion this afternoon with some of the physicians that will have more insight on the exact data comparing the two. Briefly, the oversimplified version in my pharmacist brain is that more drug is always better until it's not. So if you're someone that can tolerate the medication without extra side effects, then continuing on the treatment continuously for 28 days could certainly offer, treatment benefit because we're not having those off periods. So you are exposing more drug to the myeloma cells, but the downside is the side effects. So particularly with maintenance therapy, any type of maintenance, the goal is to give as much drug as we can tolerate to keep the disease under control and keep patients in remission, but without causing excess toxicity. So oftentimes when we're giving those off blocks, it's to minimize risk of toxicity. But I think that would be a wonderful question to bring up again to the physician panelists this afternoon.
Back to the exercise question, when you said except any heavy lifting, is there a definition of what heavy lifting is?
I will defer that to Dr. Anderson again, because I guarantee you he's going to tell you a specific weight. I think the honest answer is that it's going to be kind of patient dependent and how much bone destruction there may have been. And, even in a room of perfectly, healthy, we've never had myeloma. If we have patients, from 20 to 80, we're going to have differing levels of bone strength at baseline to begin with. So I think some of that is going to depend on kind of your baseline strength and age, and then the level of bone destruction that we may have seen on some of those scans at initial diagnosis. But I would ask that again this afternoon. Okay.
Back to the 21-day versus 28-day, do you as a pharmacist see a difference in patient compliance with their oral medications if they're taking it every day versus a week off?
It can definitely get confusing for patients when we're doing off blocks. So continuous is always easier for patients. we can do our best to set it up and say, your transition period is always going to be on this day of the week. And so we can try to say, on Sundays, think of it this way. But inevitably, there's going to be some interruption of therapy at some point because of our blood counts were too low, or maybe we had a rash. And so we've told you to hold it for a couple of weeks until the rash resolved. And now instead of starting on a Sunday, we're restarting on a Wednesday all of a sudden, and that can get out of whack. So from a patient compliance perspective, the pharmacist in me loves just staying on it continuously. It can always get a little confusing when we're trying to start and stop drugs. The best way to minimize some of that is to have tight control of the actual prescription and when it's being sent with the dispensing pharmacy. And so they can help with some of that patient compliance. So if we're only giving you 3 weeks at a time, it's going to force that 1 week off. So if the pharmacy is giving you a 3-week supply and they're billing it to your insurance as a 4-week supply, you'll run out of pills, so you can't keep going. And then the insurance is going to refuse to refill it and say that it's too soon to fill. So that can help some, but continuous is certainly easier from the patient perspective.
Back to the supplements, I've been told that turmeric helps to lower your kappa light chains. And I guess it's been documented with a patient, a British patient, who opted not to do treatment. What do you think about that?
So I'm not familiar with that specific claim or case. Turmeric does have anti-inflammatory properties, and it does act as a bit of a blood thinner. So we know that turmeric does work in the blood. And so there have been proposed, benefits for a number of different blood cancers for the use of turmeric. I generally still recommend against for a couple of reasons. The biggest is that turmeric can act as a blood thinner, so it can increase risk for bleeding. So when we're looking at combining turmeric with drugs like aspirin or other blood thinners, and then if you're on a treatment that might lower your platelet numbers, so now we're in a scenario where you have low platelets, you're on aspirin and you're on turmeric, it just might increase risk for bleeding too much for my comfort. I think in a patient that was going to defer standard treatment, that kind of takes some of those other questions out of play, because I'm sure that patient, was not on aspirin, and I'm sure that patient was not on any chemo that would reduce their platelet numbers. So some of those other risks go away. But in general, I would say no. And then again, the big question is, just because the bottle says you're getting X milligrams of turmeric, there's no regulatory body monitoring that to guarantee that you're actually getting that dose of turmeric. So you could underdose or overdose pretty easily.
I have a question about dexamethasone, which many of us are taking. First of all, I've been fighting this disease for 17 years.
Wow.
And so,
Yeah.
thank you. Yes. With the Dex, what works for me, I'm not saying this works for everybody, but what works for me is to take the Dex at bedtime. I mean, like right when you turn off the light. And the reason is because it has, for me, a 7 or 8 hour window before it kicks in. And then that helps me. That's something that I found. And so that's my usual strategy to do that. But in the last year, I've been taking the immunotherapy, the Darzalex, which is fantastic. My numbers dropped 80% in a week. So they're all normal. But as you as a pharmacist, I wanted to ask, what happens at UT Southwestern is that the nurse comes in and she says, I'm going to have the pharmacy release the Darzalex, and then she comes back a half an hour later. But the question she asks me is that, when did you take your Dex? And so I want to know what should be the timing of that? I mean, could I have taken it first thing when I got up that day, or do I have to wait till I get to UT Southwestern to take it?
So that's a wonderful question. So one of the main counseling points when we talk to patients about steroids or dexamethasone is that it can make it difficult to sleep. And so I generally tell patients to take it first thing in the morning. So doing it right before bed, in my opinion, is a bit unusual, but is a perfect example of how knowledgeable patients are and how that experience and how it works for you and for your own body is invaluable. And those types of things could help other patients through CureHub, kind of documenting, some of those types of things. So that's wonderful. For most patients, I will say, taking it right before bed, you're probably not going to sleep that night. Some patients will have a much faster onset of action than that. I would say that 8 hours is a little bit unusual. So I generally recommend patients to take it first thing in the morning. But if you've done that and tried it, and through years of experience and trial and error, you realize that then it kicked in 8 hours later and you couldn't sleep at night, then modify it to you. The second part of that question then was timing with your Darzalex. So that brings up then the point of potential for infusion reactions with Darzalex. We know that infusion reactions were very, very common when we were using it as the IV formulation. They did a long, slow infusion to help prevent some of that. Now that we have the subcutaneous, where we're just doing the Darzalex shots, that risk for infusion reactions went way, way down. It still happens, so it's not impossible, but it went way, way down, and it primarily happens with our first couple of doses. So if we've, been on treatment for months and years, then we're incredibly unlikely to have that reaction with the Darzalex. So the nurse asking, when did you have it? When did you take your dexamethasone? Is a factor of asking, are you at risk for an infusion reaction while you're sitting in my chair? And so they generally would like to have seen the dex within 4 hours prior to the dose to minimize risk. So we'll say anywhere from 4 hours before to 30 minutes before. So if you get there and you said, oh, I forgot to take it, or, I took it yesterday, they'll probably want to give you a dose of dex while you're there. But if you are, in cycles 2 and beyond, and you've had several doses with no risk or with no previous infusion reactions, then they can probably get some of those communications and things taken out where the nurse doesn't have to ask that. Wonderful. All right. Thank you, everyone, for wonderful discussion and questions. So I appreciate your candor and participating with me in the discussion today.